We take very seriously the processes that we put in place, so that grant was withdrawn and will be resubmitted. More specifically, the actions, Madam Chair, that we're taking is that from now on we're going to monitor every peer review committee with a third-party auditor. We've hired a compliance officer who will look at every grant and assure us that all of the I's are dotted and the T's are crossed. We are developing a new incubator RFA that not only will include a commercial review by commercial experts, but also a scientific review. Last but not least, we're continuing our regular audits. CPRIT has been audited 19 times in our first 3 years, and I'm pleased to have audits come in because it gives us areas of focus where we can improve our activities. But last but not least, we've initiated a futures directions effort. I'll talk a little bit about that in a minute, but thank you.
Thank you. And members, Dr. Jensen and I have spoken about this one-on-one, and I do believe that our peer review process is one of the most highly respected in the country, and was very concerned when, and I just want to clarify what you just said, that the grant did go through a peer review process. That's correct?
Yes, ma'am.
And the original request for application, as approved by the Oversight Committee, only required the grant to go through the commercialization peer review process, correct? And I understand these type of grants are now required to go through the scientific peer review process, but that change to the policy, that is a change to the policy that was in existence at the time that this grant was originally approved.
Yes.
That's right. Okay. Well, I believe so strongly in the mission of CPRIT, and I want to make sure that we stay on track to reach our original goal in creating the Institute, and that's moving us closer to a cure for cancer. I really look forward to your presentation. And members, any questions on that original? Senator Uristi.
Thank you, Madam Chair. Good morning. I have a question on your handout.
Yes.
Where you state more than 14,000 jobs are created, and then there's an asterisk next to it. Can you talk a little more about that, please?
Yes, that is on an annual basis. We have to, by law, develop the annual cost of cancer in the state of Texas. In addition to that, we look at the economic impact of CPRIT funding. That 14,000 jobs that have been created is an economic analysis that's done by the Perryman Group.
Do you know where those jobs are being created at?
Senator, I could find out specifically. I think it's more of a general sort of upstream and downstream analysis, looking at the dollars that are being invested, across the state.
Could you provide us with that information?
Yes, sir.
Thank you.
Let's go ahead and have you deliver your presentation, and I think there'll be more questions after the presentation. Thank you. Go ahead.
Well, good morning. What I'd like to do is give a brief update of CPRIT, the Cancer Prevention and Research Institute of Texas, but then spend a little bit of time on the type of research that we fund. If you go to the first slide after the cover, to date, CPRIT has funded 384 grants, totaling $645 million. 281 of those grants, or 75%, fall in the academic research category, including, I'm pleased to say, 38 CPRIT scholars in cancer research that we've attracted from other states to come to Texas. We also have awarded 91 prevention grants where we've actually screened 100,000 Texans for colorectal cancer, breast cancer, and cervical cancer, areas where we know we can truly make a difference. And almost 30%, or 30,000 of those individuals, of those Texans, had never been screened before. So we know we're hitting the most underserved and productive population. We've invested in 13 companies. That averages about 15% of our total investment. And those 13 companies are attracting follow-on capital from outside of the state of Texas to Texas. To date, we've been able to document $200 million of additional capital coming in related to those companies. If you go to slide 2, you'll see that CPRIT funding, has resulted in $2 billion of economic impact to the state. We know that for every dollar that CPRIT invests, it results in $1.99 in state and local tax revenue. Our goal is not only to reduce the $28 billion And again, that's $28 billion that we spent on cancer in calendar year 2011. But also what we want to do is bring money back to the state. I'm pleased to say that we're starting to see that, albeit small, but we are indeed bringing dollars back to the state of Texas. If you go to slide 3, you'll see that, we really fund all types of research. And Senator, there's certainly a whole group of scientists, following me who can be very specific about basic research, translational research, and clinical research. But from a lay perspective, I would say that basic research really is the building block of all research. It's research where one follows the results with no specific end in mind. In other words, you go where the scientific curiosity leads you. The next type of research is translational research, which will take the findings of basic research and actually try and solve a very, very specific or defined problem. And last but certainly not least is clinical research, which is patient-oriented, directly touching patients, usually looking at safety and efficacy of products. If you look at slide 4, you'll see that more specifically at CPRIT, our translational research is looking to apply basic research findings to prevention and treatment of cancer. We want to bridge the gap between the laboratory on one side and the patient on the other. And as soon as translational research ends, we actually begin the drug or device being studied in humans. So we are very focused on our effort of trying to increase translational research at CPRIT. On slide 5, you'll see
before you go on, can you talk just a little bit more about, because our focus on translational research is so important because it deals with our actual development of new treatments, but clinical research really is that last step in the process, getting those treatments to the patients. Can you fill in that gap a little bit more between the connection between the translational research and the clinical research?
Well, and again, Madam Chairman, basically when we look at translational research and you're actually trying to define, a very, very specific problem such as, will a drug, is this drug ready to be tested? Mm-hmm. Once that testing starts in what we would call a clinical trial, whether it's a phase 1, phase 2, or phase 3 clinical trial, that translational research takes, that effort all the way into the, I guess what I would argue, into the clinic. So clinical research, really, as you said, is the ultimate goal. What our focus is to invest as much as we can in products and in drugs, devices, and diagnostics that will move through that research continuum and get to clinical research as quickly as possible. Mm-hmm. And I must say, we've actually invested in a statewide clinical trials network where we're soliciting good ideas and soliciting projects to be plugged in to either phase 1 clinical trials or phase 2 clinical trials.
Okay. Senator Zafrani?
Yes. Is there significant research being done that focuses on cancer survivors who have disabilities as a result of cancer treatment?
Senator, that's a very good question. We do have an evidence-based prevention program, and under the statute we can spend 10% or $30 million a year. A number of those projects actually focus on evidence-based efforts around cancer survivorship. Also, any prevention research, a prevention research project where you may have, you may be comparing, one cohort to another in terms of prevention activities, can be funded through CPRIT, through the research category. We've actually funded some of those projects also.
Good. Thank you. Mm-hmm. Madam Chair. Go ahead.
Yeah. But again, on slide 5, if you look at the Venn diagram, you'll see that at CPRIT, to date, we have funded 38% basic research, 19% translational, and 4% clinical. And Madam Chair, you may ask how we come up with those percentages, because the definitions are a little bit loose. So we actually ask the researchers. When the researchers put in their application, we say, tell us, is this basic, translational, or clinical? And obviously 38, 19, and 4 don't add to 100% because, these areas of research overlap. So a project could be basic and translational, or translational and clinical. And so that's why you really don't get exactly 20.
That seems like a low percentage on clinical.
Yes.
There was so little, 4%, especially considering our original goal when we created CPRIT of getting cancer treatments to the public more quickly.
Well, that's why we're looking at this data, so we can really redirect some of our efforts.
Mm-hmm.
It does make sense that basic would be larger to some degree than translational, and translational would be larger to some degree than clinical. And I'm going to talk a little bit about the Futures Directions Initiative. What we're looking at now is trying to get advice from scientists, researchers, and others around the state of Texas to help us focus more on translational research and focus more on clinical research. And as you'll see coming up in slides 6, 7, 8, and 9, you can see where CPRIT has actually increased our translational initiatives. So, Senator, if you move to slide 6, we do have, number one, the Texas Life Science Incubator, which, we put into the category of translational research because we're trying to enhance our ability to commercialize, new and innovative products. Also, we have a new request for early translational research awards. So about 8 months ago, we issued a request to all of the scientists in Texas and said, give us your best projects on translational research. We had about 50 projects come in, and we actually funded 9. So again, that's an effort to start moving us closer to translational research and therefore closer to clinical.
Well, one of our major goals when we created CPRIT was to not duplicate the research that was being funded by the National Institutes of Health.
Correct.
And I believe that goal was discussed at that first meeting of the directions, new directions.
Yes, ma'am.
What's the name of the?
Yeah, the future
directions.
Yeah.
How can we use that new work group to ensure that we avoid that duplication?
Right. I think a couple of ways. Number one, we decided that we wanted to do futures directions because, we stood the Institute up so quickly. Mm-hmm. And we didn't, it was a green field. We couldn't figure out where we were going until we understood where we are. Mm-hmm. And so we looked at this, and now we know exactly our research, our funding portfolio. So we're bringing in individuals from all of our 6 advisory committees, that include our Commercialization Strategy Committee, our University Advisory Committee, our Scientific and Prevention Advisory Committee, our Advisory Committee on Childhood Cancer. And these experts, researchers, patient advocates, industry individuals are going to look at this portfolio and help us, be different. Help us move more towards an institute where I can sit here in 7 years and come back and say we've had some tremendous successes, we've had economic benefit come back to the state of Texas, and the people of Texas will be proud of what we've done.
Good. That's our goal. Senator Dill?
Well, just to kind of add to that, when we were developing this with Senator Nelson's leadership, it seemed like these funds would be to sort of fill in the traditional holes in mainstream research grant funding, that there were things people wanted to do, but they didn't quite fit in, and that we would fill in these holes and then hence complete the research picture. Do you feel like, is that an accurate assessment, and do you feel like we're doing that?
Senator, I believe we are in certain areas. We do have a high-impact, high-risk proposal where, we ask individuals to come in. It's a small amount of money, but we say, look, give us your wildest idea. Put it on the table, and, we're willing to fund this, and it may fail, but that's where we're trying to fill in the gap. The recruitments, we've actually recruited 38 individuals, top-notch scientists from around the country to come to Texas. That certainly is filling in, a gap that wasn't met before.
Yeah, well, history is filled with medical researchers who were thought to be somewhat crazy at the time, starting with Ignaz Semmelweis, the Hungarian obstetrician, and so forth, and even Salk and had his detractors and all that. The other areas that once you grant it, are these research projects being monitored in terms for the?
Actually, and I had an interesting conversation this morning that the actual approval of the grant is really the first step. After the approval, we go through a very extensive contracting process, very detailed, with milestones for every project, whether it be commercial, academic research, or prevention. We have a return on investment requirement with every grant. So every grant has some kind of agreement where money will come back to the state of Texas, and our progress reports actually go back to the peer reviewers who approved this in the first place. So folks from outside of Texas will look at the quarterly or annual progress report and say, yes, this project is fulfilling, what they said they would do, or no, they are not.
And just to point out, sometimes the answer is no. In other words, you do research and you find out that your theory was wrong, but that's not a bad thing,
right?
As long as you've spent the money wisely getting to that point, because then you prove something that other people don't have to look at, that this just doesn't work to that area, and you can go on. So but I'm concerned with how the money is spent and coming up with whatever answer we get.
And I think you're really going to like hearing about the Future Directions initiative.
Okay. Thank you, Madam Chair.
Senator Zaffirini, then Senator Rodriguez.
Thank you. On page 5, which of course is related to page 6, you reference drugs or devices. Are any of the devices related to your research focusing on rehabilitative and assistive technology?
Senator, I'm not sure. I don't believe as of yet. I mean, we do have, of course, the devices are a much more limited number. We've had some tremendous success on the commercial side with a couple of devices. For example, a company right here in Austin, Apollo Endosurgery, who developed a device for the removal of flat colorectal cancer polyps. And that device has actually been approved by the FDA and is now being used in patients. But to answer your question, I would like to get back to you for the record, but I'm not sure we are.
It seems to me that the funding model you show on page 6 would be perfect for that kind of research.
Now the incubator, the Texas Life Sciences Incubator, yes, ma'am. We are very interested in the incubator. That is the RFA that we've taken back, and we've decided rather than just a commercial review, we want to have commercial and science. So I would predict that we are going to see some excellent projects come through that request for application.
And I hope you're correct.
Thank you.
Thank you.
Thank you. Senator Rodriguez.
Thank you, Madam Chair. I wanted to follow up on what the chairwoman asked about duplication with the National Health Institute research. But my question is related to the ongoing efforts by other institutes here in Texas, not the National Institute of Health. And we're going to have some testimony from the MD Anderson and the Methodist. Do we also try to avoid any duplication with those, or do we complement their research? How do we interrelate our research with those other institutes?
Yes, Senator. First of all, we do have a number of advisory committees, and one that is statutorily created is the University Advisory Committee. Mm-hmm. So they represent all of the systems in the state of Texas, and that's a way we can, bring individuals together and make sure that we are actually providing value and not just duplicating what other institutions may have been doing anyway. I noticed that the Emerging Technology Fund will be here today, and we are in constant communication with them to make sure there's no duplication. So we strive to ensure that there is no duplication and that CPRIT is really truly going to be different. Mm-hmm. Again, getting back to the Futures Directions Initiative, we have to try and reinvent ourselves every year. We need to look at ourselves and decide, are we really doing what we should be doing, and are we making a difference? And I think that's critically important. And at these meetings, we don't speak. We sit there and we listen to some of the best researchers, some of the best patient advocates, some of the best prevention folks in the state, telling us, how are we going to, what will success look like? How do we define that roadmap? So duplication in some cases is not bad, because if you don't have a little duplication, you're going to have a gap in an area. But we really do try and avoid any duplication or, being, another NCI.
And one follow-up question. You mentioned earlier that our costs have increased up to $28 billion. I was just curious to see how that compares with other states, California, New York.
Well, I would think, per capita, we're probably in the same ballpark. Obviously, with the number of cancer cases, we have over 100,000 cancer cases in the state of Texas, annually, and rising. So $28 billion is certainly a hefty number and would be more than most states. but I can get that information for you, especially with comparison in terms of per capita.
Thank you.
That's great. Go ahead.
Well, Senator, again, just looking at some of the projects, we had that new request for application for translational research. 50 proposals came in. We actually funded 9, so we're very excited. And these requests for applications will continue to come back up. We do have a recruitment of translational research investigators. I don't believe we've had anybody apply under that as of yet, but I need to check. But we're interested.
When did that open up?
Probably about 8 months ago.
Huh.
So basically what we've said to the academic institutions in Texas is if you identify somebody whose expertise is in the field of translational research, that they can apply under, this particular recruitment request for application. We have the same with clinical. So we do try and stimulate clinical researchers also coming to Texas.
Yeah.
But to wrap up my presentation, I wanted to talk a little bit about the future's directions, even though, we've mentioned quite a bit about it. But we decided that we really wanted to take a very serious look back at CPRIT and examine everything that we've done. And obviously this comes at an opportune time. We would have done it anyway, but now it's even more important for the Institute. I want to find out what have we accomplished, how can our processes be improved, and what remains to be done so we can actually develop this roadmap for success. And again, the best way, I think, is to bring the folks in, who, help us start this in the first place. Bring in the researchers, bring in the advocates, bring in the prevention experts, bring in, patient advocates from around the state of Texas to engage with us. We had our first meeting about a month and a half ago here in Austin, where 30 experts sat in a room for 4 hours, and we listened to all of the recommendations. We're going to have 4 town halls, one in Dallas, one in Houston, one in Lubbock, and one in San Antonio. And then to cover the state, the areas of the state where we haven't touched, we're going to develop a webinar so South Texas and other locations can join. We plan to unveil these results at our annual conference, which will be at late October. And then after we unveil the recommendations, we will take those pared down to our oversight committee for approval. And again, I would like to do this on a continuous basis, so we're held accountable. So the people of Texas and you can say we know exactly what CPRIT is doing. Transparent can be. And with that, Madam, thank you so much.
Can you give us a teaser, even though you're not going to unveil until later? I mean, just some general themes that might have emerged that would, in terms of where our research dollars should be focused.
Yes.
Give us some ideas.
So as I mentioned, academic research right now with the almost $700 million that we invest represents about 75% of our investment. Commercial research represents about 15%, and evidence-based prevention, which is in the statute, is 10%. At the highest level, and again, this was a group of individuals where 48% of those folks sitting around the table represented academic research. So, it wasn't just prevention folks or commercialization folks. The majority represented, academic research. They felt that academic research or the research category was funded adequately or could be reduced. They felt that commercial research should be increased. And they actually recommended the evidence-based research where we provide patient education, provider education, and screening for colorectal cancer, breast cancer, and cervical cancer, because we know we can eliminate cervical cancer in the state of Texas, so 400 women a year won't die. And we also know we can cut colorectal cancer in half in the state of Texas. This group came together and they said maybe we should go back and ask the esteemed members of the legislature if they would increase that 10% a little bit. So that's a little bit of a teaser, a little bit of
the prevention dollars.
The prevention dollars,
right.
Yes, ma'am.
Good.
Yeah.
Senator Rodriguez and Senator Zafferini. Rodriguez. Senator Uristi, that was an early morning test.
No, thank you, Madam Chair. So following what you just said, of the cancers that are preventable, what about cancer as a result of those that smoke?
Well, Senator, of course, the direct relationship, to cancers of smoke is tobacco use. And I'm pleased to say that one of our advisory committees came forward with a recommendation that if you get CPRIT funding, then you must be tobacco-free. So we've implemented a policy where any grantee that accepts CPRIT funding, must have a tobacco-free policy. And that's a carrot, it's not a stick. We're just saying, look, we're in the cancer, prevention business. We're in the business of defeating cancer in Texas. We have to be able to say, this facility must be tobacco-free to support that. But we are interested, obviously, in prevention of lung cancer.
I'm just curious if you mentioned the cost of cancer in Texas is $28 billion. How much of that is related to smoking-related cancer?
I could get that data for you.
And you talked about the 400 women's lives we could save, which is wonderful, but I bet you there's probably thousands of other lives we could save if we focused on that one issue, which is obviously a preventable cancer.
Yes, sir.
I know it's not an easy task, but are there any other efforts y'all are using to prevent that type of cancer?
You mean cancer across the board? Well, certainly, provider education.
Related to smoking.
Pardon me? Related to smoking. We do work very closely with the state quit line, because we know that, that has a very, positive result for smokers. We do, look at public education and provider education. We certainly are very interested, again, as our policy, stating, tobacco-free is very important for us. We do juggle this a little bit because, the smoking effort is so large that, we want to make sure that we invest our dollars, wisely. I mean, we do know, for example, in cervical cancer, women, 20 years ago we were talking about eliminating cervical cancer prior to any vaccine, because we know with the pap smear that cervical cancer can virtually be eliminated.
But there's two doctors here.
Yes, sir.
I'm not a doctor, but
Yep.
I think the research has been done that if you smoke, you're going to get sick and you're probably going to get cancer. I don't imagine we have to spend a whole lot of money on researching that issue.
Now now smoking, there's no, absolutely, there's no more research required.
Exactly.
I think if you're going to do any research in smoking, it would be, behavioral research to look at, ways that, we can encourage young folks not to smoke. And I think the most, successful would be to really make sure that our young people, avoid smoking. So, again, we do have education programs. We do fund, education programs across the state of Texas. Prevention, these evidence-based prevention projects cover the entire state. And I could get you a list of all of the projects that are related to tobacco cessation.
If you could get that, and also what the cost to Texas is for those smoking-related cancers. Thank you.
Thank you.
Okay, Senator Zeffirney.
How much or does any of your behavioral research focus on nutrition-related and environmentally related causes of cancer?
Senator, certainly nutrition-related. We're obviously, there's an association we know between obesity and cancer. We are looking at, a number of evidence-based projects that do look at, nutrition-related. And again, I could get you the list of those projects. Related to environmental, I'm not quite sure, and I'd have to get back to you on that.
Thank you. I would appreciate it.
Okay. I think we'd probably all like copies of that. Mm-hmm. Other questions? Thank you. Really good presentation, and we're really anxious to see what the new direction, I keep wanting to call it new directions.
Yeah. Future directions.
Future directions, what emerges from that. That is, I'm really excited about.
Well, Madam Chairman, thank you, and thank you for your time.
Thank you for your work.